Terrific. So it looks that as now we're beginning to get ready to start our webinar, it looks like we still have participants joining. So we're just going to wait a moment as the participants continue to enter the webinar room here, and then we are going to begin our conversation today. Thank you all so much for joining, those of you that have been on the line. And again, additional participants are filling, and we're very excited about the kind of participation that we've seen from across the country. So we'll just be another moment as folks join this conversation today. Okay. Good afternoon. I'm Ilario Pontano. I'm with Syracuse University's Institute for Veterans and Military Families. I'm very happy to be here with you. It's a somber occasion, but it's an important one. This is the second installment of a series of webinars to discuss prevents and the President's roadmap to empower veterans and end the national tragedy of suicide. I'm going to very quickly address an agenda, and we're going to look to the program. And I just want to make a reminder that while we've originally scheduled for 60 minutes, we are going to have a robust question and answer session moderated by Dr. Nick Armstrong with all of our panelists. So we ask that you please remain, if you can, to take it to about a total of 90 minutes. Again, we're being joined by participants from all over the country, mindful of different time zones, and want to be respectful of your time. But with that, I'd like to introduce to you the IVMF Chief Operating Officer, Ms. Maureen Casey. Maureen is responsible for all aspects of the Institute's daily operations, personnel, and financial activities. She brings more than 25 years of public and private sector experience to her current leadership role. Prior to joining the IVMF, she led JP Morgan Chase's efforts to develop and implement a comprehensive firm-wide strategy to assist members of the military, veterans, and their families. Prior to joining JP Morgan Chase, Ms. Casey was a senior vice president with the global consulting firm Giuliani Partners from 1997 to 2002. She was employed with the New York City Police Department initially as counsel to the first deputy commissioner, and then as NYPD's deputy commissioner for policy and planning. So with a strong managerial and law enforcement background, leading the IVMF, would like to introduce my boss, Chief Operating Officer, Maureen Casey. Maureen, thank you.
Thanks, Ilario. Good afternoon, everyone. I'm honored to welcome all of you to today's webinar. For those who joined us 2 weeks ago for our introductory session, welcome back. And for those who are joining us for the first time, we hope that you will find your time with us today informative and helpful. With the news reporting this week that active duty military suicides have increased as much as 20% this year compared to the same period last year, and Blue Star Families SAMHSA Pain Points poll results finding that military and veteran families reported concerning impacts brought on by COVID, among them increased stress and incidence of mental health symptoms. Our focus on this most pressing national issue could not come at a better time. The IVMF at Syracuse University very much welcomes the opportunity to partner with Dr. Van Dalen and the Prevents team on their mandate to tackle the national crisis of veteran suicide. As we know, the numbers are completely unacceptable and therefore require an all hands on deck approach. And that's what today's session is all about. Resulting from the President's executive order last year, the Prevents Roadmap is an action plan to do what its name indicates, empower veterans to end the national tragedy of suicide. And this most important work of the White House and the VA through the Prevents Task Force is but one significant step in this fight. Just 2 weeks ago, compromises were reached between the House and Senate on veteran suicide prevention bills, the Veterans Compact Act and the Commander John Scott Hannon Veterans Mental Health Care Improvement Act. Truly game-changing in this critical effort. And then we have today's discussion with all of you, digging a bit deeper into the roadmap and what it means for states. In addition to hearing from Dr. Van Dalen, we will hear from other leaders in this fight. Dr. Richard McCune, Chief of Suicide Prevention from SAMHSA, and Dr. Matt Miller, Director of the VA's Suicide Prevention Program. More people, resources, and actions moving us in a forward direction to address this most pressing challenge. On the screen, you will see some background information regarding veteran suicide, particularly the third bullet, that more veterans have died by suicide than in the wars of Vietnam, Iraq, and Afghanistan. Again, truly tragic and outrageous. At the IVMF, we are singly focused on positioning those who have worn our nation's uniform and their families to thrive after service. And that is why this partnership with the task force is so meaningful to us. We are aligned in mission and in how we accomplish it. The answer lies in a nationwide community-based approach and a robust community engagement. Our decision-making must be informed by the data. And we must continue to build partnerships and leverage one another's strengths. And finally, we must focus on prevention. For suicide can be prevented, but it requires more than intervention at the point of crisis. It is complex and demands a comprehensive response. For those of you who might not be familiar with the IVMF, we were founded almost 10 years ago at Syracuse University, and we have served more than 142,000 transitioning service members, veterans, and their families through our programs and services, which are singularly focused on positioning these folks to thrive. We develop and deliver career preparation, training, and employment programs. One is Onward to Opportunity, an end-to-end solution offered on installations and online to service members, veterans, and spouses. It provides industry-recognized training, credentialing, and employer connections. A second, the Arsenal, is a portfolio of entrepreneurship training programs designed to meet participants wherever they are in their entrepreneurial journey. We are also working alongside communities across the country to help them better serve veterans and their families in those communities. For we know from our research that access to and navigation of care and services is one of their greatest challenges. Finally, our research and analytics organization is second to none. Whether conducting surveys alongside Blue Star families, performing original research regarding compelling policy issues confronting those we serve, or analyzing the outcomes of our programs or the programs of others, we are among a select few that do this work in addition to the direct program service delivery. And all that we do is set within the Syracuse University community, which means we are able to leverage all of its expertise and resources as well. As I mentioned at the start, this is our second webinar in a series of 3. Yes, a total of 3. This work is that important because those we all serve are that important. While we can never repay the debt for their service, we can ensure that they have access to the care and services that they need when they need them. Our final session, scheduled for October 14th, will be very tactical, giving more detailed information on leveraging the tools and resources that are available to all of you. And now it is my honor and pleasure to introduce to you the Executive Director of the Prevents Task Force, Dr. Barbara Van Dalen. On March 5th, 2019, President Trump signed Executive Order 13861, entitled The President's Roadmap to Empower Veterans and End a National Tragedy of Suicide. This executive order created a dedicated task force to coordinate efforts across government to build a national strategy focused on improving overall mental health to prevent suicide. To lead this multi-agency national effort, Dr. Van Dalen was selected as its executive director. Named to Time Magazine's 2012 list of the 100 most influential people in the world, Dr. Van Dalen is the founder of Give an Hour, a national nonprofit that provides free mental health care to those in need, including service members, veterans, and their families, an organization she led as president until 2019. Dr. Van Dalen also founded the Campaign to Change Direction, a global initiative focused on changing the culture of mental health. Change Direction is a public health approach that encourages everyone to learn the 5 signs of emotional suffering that signal someone you know may be suffering emotionally and may need help. A licensed clinical psychologist who practiced in the Washington, D.C. area for over 20 years, she received her PhD in clinical psychology from the University of Maryland. Dr. Van Dalen is an expert on the psychological impacts of war and a thought leader in mobilizing constituencies to create large systems change, and is widely recognized for her work in changing the culture associated with mental health. Dr. Van Dalen has been a regular contributor to the Huffington Post and Time, among others, and has been interviewed by major media outlets, much too numerous to mention. Importantly, her father was a World War II Navy veteran. All of this to say, she is the right person to lead this effort, and it is my pleasure to introduce you to Dr. Van Dalen.
Thank you, Maureen. It's so lovely. I greatly appreciate that kind introduction. And I'm thrilled that we are creating this opportunity to educate as many as we can possibly reach with the work that we're doing through Prevent. And our partnership with ivmf is so critical. It is really a beautiful example of what Prevent is all about, which is partnering with everyone, everywhere. So today we're going to go a bit deeper. For those of you who are with us for the first webinar, thank you. Thank you for coming back. I hope it was helpful. And today we're going to go a little bit further and talk more specifically about what Prevent is doing at the state and community level. And I couldn't be more thrilled. Well, first of all, I'm thrilled to be able to talk about what we do, because this is my passion and has been for my entire career, is building these kinds of efforts and systems that reach people who are struggling and empower them with tools and resources. And it happens at the community level. The other thing that Maureen didn't mention, because she probably doesn't know this, but I actually grew up in rural California in a very teeny tiny community with my dad, who was a veteran, and my 3 older brothers. And it was all about community. It was all about people taking care of each other and helping each other. And so I love this work. The other reason I'm thrilled to be back with you today is I'm joined today for this discussion with 2 of my favorite colleagues, Dr. Richard McKeon and Dr. Matt Miller, both of whom contributed significantly to building Prevent, both of whom we have snagged to make sure that they continue to join us, work with us, because this truly is an all-of-government effort. So I'm delighted and grateful that they have agreed to provide chunks of the information today. So with that, we're going to go right into some slides that I'm going to share with you to give you a sense of what we are doing with our efforts at the state and local level. So next slide. There we go. So just to remind folks, our aspiration. So this is a mouthful, but it is exactly what we are doing. Prevent will prevent suicide within the veteran community and lead the way in preventing suicide for all Americans by employing a public health approach to empowering every individual through a nationally driven, community implemented 4-part integrated strategy. I said it was a mouthful, indeed it is, but it is what we're doing. So what does that look like? Our work is focused on these 4 major areas of focus. We have there's literally 164 that are nested, broken up into different specific recommendations that fit under each of these 4 areas. So every time we step into a state or community, we are focusing on these 4 simultaneously, and with our work with our government partners. So I want to talk briefly about what the 4 areas are and what does success look like, because that tells us what are we doing in your communities? How do we want to partner with you to achieve this? Communications campaign. So we launched on July 7th a massive public health campaign. I'm going to show you little snippets about that in a little bit, to really drive this culture change around mental health broadly and suicide prevention specifically. It's the first ever national public health campaign focused on suicide prevention, and we're really proud of it. And it's called REACH, and again, I'm going to show you more about that. So that's the focus area. So what would success look like? What will success look like? What we want to do by launching this, so public health means it's for everyone, everywhere, massive amounts of information, simple, clear information that everyone can grab onto. We want to develop and create a strong awareness of risk factors for suicide and the adoption of help-seeking behaviors in all communities and veterans in particular. We want to create a culture of openness, support, and belonging surrounding the topic of suicide and mental health more broadly. So that's what we're driving towards. So all of our efforts in the communications space are focused on achieving those goals. Research, our focus area of research, the goal, the overarching goal, the vision, is to prioritize precision suicide intervention and enhance the federal research ecosystem. Well, what does that mean? That means we want to move toward understanding more which interventions, which efforts are better for which individuals. A 70-year-old veteran, how we reach him or her, what interventions might work for him or her, is much different than what it might look like for a 25-year-old veteran. So what will success look like when we move in that direction? And also we want to just make it easier for our federal government agencies to share information, to analyze data, to integrate it, to translate it. And we want to bring in outside data from our non-government partners in the same way. So prevention and intervention methods tailored to each veteran's unique suicide risk profile. That's what we want to start to create. So we'll know, so that we can go after, that we can intervene early, but we have to create the knowledge that tells us what factors, what tools. And this enhanced federal research ecosystem, when we have it, we'll see that we're promoting team-based research activities, public-private partnerships, shared resources, frequent engagement with government funders and regulators and all of our state partners. And all of these things, everything I'm talking about, we're tracking. We can track them, we are tracking them. Programs, scale data-backed programs at the community, local, state level. Obviously, that's where all of you, that's your sweet spot, that's where you live and breathe, that's where we want to partner. We want streamlined access to comprehensive end-to-end mental health and suicide prevention care for all communities with a specific focus on veterans. We want that comprehensive, coordinated effort. It's the only way. That's where we're heading. It's aspirational, but we'll get there. And what else we'll see? Active suicide prevention initiatives and conversations in the workplace, in schools, faith-based communities, and other stakeholder organizations. Finally, in the policy space, develop and support policies to improve prevention. That's our focus. What does that look like? Legislative proposals that drive grant funding to communities, enabling them to increase collaboration and integration. So we don't want to dictate what y'all are doing, but we want to look for evidence-based efforts, evidence-informed efforts, and support those. And also we'll see universally driven and adopted policies that allow for more coordinated action-oriented research and the implementation of evidence-based suicide prevention programs. That's a lot, but that's what we're working on. Next slide. We have 3 specific priorities for 2020 that we're working on, and we're well on our way to achieve them all. But I want to just tell you kind of what they are, because they're very focused on the state, local, and community efforts. Priority 3 of our 9 priorities, state, local, and community grant programs. Leverage existing federal agency funding priorities to support, prevent state, local, and community grants, and prepare for grant implementation, meaning prepare for future funding. So right now we're working on developing a state local data implementation plan. What does that mean? We're gathering data, we're gathering information so we know what states are doing. We know what's effective, we're capturing it so that eventually we can share it. So it helps us identify gaps. We're also have been working to create a database to track all of the current grants that are available focused on veterans, mental health, suicide prevention, and community outreach. Right now, we've been tracking over 140 grant programs that total $2 billion in funding. Why are we doing that? Because rather than just going, hey, we think we need more funding over here or over there, we want to be able to actually identify and also, again, share with our partners, what is it that's needed? How do we bring more resources and resources that are going to fill gaps? Next slide. Priority 4, state, local, and community integration, activation, and collaboration empowerment campaign. What does that mean? So eventually we want to bring additional resources into your communities. But before we do that, I mean, we have a lot going on right now because we want to enhance what you're already doing. So increase capacity at all levels to begin or enhance existing implementation of prevents recommendations to prevent suicide, promote a stronger sense of belonging and purpose among community members, including veterans, build collaborations. So this is what we're already doing. We're not going to wait for funding to flow. We're working on that, but we're also working on gathering best practices, developing partnerships, partnering with groups like ivmf to make sure we're getting this information out into communities like through this webinar. Next slide. 5th priority. I mentioned this when we were all together before, our state proclamation. So we are thrilled that we have currently 43 signed state proclamations from governors, 42 states, 1 territory. Why are these important? Because they create an agreement between prevents and all of these states. So if your state isn't one of these listed, please reach out to us and we will work with you to see how we can get your governor to sign on. It's not a heavy lift. And we've been spending the entire month of September gathering these beautiful proclamations and then elevating them, pushing them out through social media, thanking the governors. This gives us a basic agreement that we're going to do these things together. Next slide. Okay. Our state visits are very much a part of the 3 priorities that you just saw. So here's where we've been already. I love the seals. They're so beautiful and so reflective of the states. So these are the 5 states that we visited and we in person that we did those before COVID. And then since then, we are now doing virtual state visits. We'll talk more about that a little later in my presentation. We've been to Indiana and Oklahoma virtually. The benefit actually of doing the virtual state visits, now that everybody is familiar with how to Zoom and how to do these online events, we can actually meet with people from across the state, literally all across the state, while we were doing these visits. When we were in the other 5, which I love in-person visits, and it was great. I went back to my home state of California, and we were in Southern California, we were in Northern California. If any of you know California, it's a big state, same with Texas and Arizona. So we had to cover a lot of ground. So literally we can do more work in a way through these virtual efforts. Next slide. Okay, prevent state visit audiences. Who do we want to reach when we come to visit your state? These are the groups that we're talking to. Obviously, state leadership. We've already had several state visits where either the governor or very high state officials participated. We've met with various members, state legislators. So we want that state director of Veterans Affairs, of course. We want those folks at our meetings. We do a leadership roundtable for each state visit. We also reach out to healthcare and mental health providers across the state, suicide prevention advocates and experts, first responders, critical. They're one of the populations we focus on because they too are at high risk. Faith-based communities. We have a huge effort, initiative, focus on engaging, working with, coordinating, promoting the work of faith-based communities, educators, colleges, universities. So as you think about, if Prevents is coming to your state and you want to be, part of this, which we want, and you want to be helpful, these are the folks that we work with, and sometimes there are others as well, but this is sort of our core. For example, when we were in Oklahoma, we also met with the tribal government leadership, because that's another subpopulation that we're focused on is our Native Americans. So think about how you can help us engage these folks. And typically what we do is we're in the state, virtually. We did this when we were visiting in person. We would be there, 3 or 4 days. Now we're typically doing 3 days as for a virtual state visit, and we do 8 or 9 virtual roundtables across those days and work with these different groups. Next slide. So as I said, we want to engage. These are some more of those beautiful proclamations. Work with Prevents. When we're visiting the states, we want to work with our state leadership and the state organizations on the specifics of the proclamation. You can see the proclamations on our website at va.gov/prevents. They're all there in their glory. They're all the same template. It's just the beauty of each state's actual seal and logo. They're really beautiful pieces of art. But it's basically the same. It says we are going to work together in these ways. We're either going to work through the Governor's Challenge or Mayor's Challenge or some other coordinated suicide prevention effort. And there's some other things that are going to promote the REACH campaign. So you can take a look and see what are the things, and on our state visits, we're working on these things while we're in that state. Next slide. Huge. We want our state partners, our community partners, to promote our REACH campaign. REACH is the first ever public health campaign, national public health campaign focused on suicide prevention. It is a massive effort. You're going to see more and more and more of REACH on platforms that you visit, on digital platforms, whether it's social media or other web pages. You'll see ads on television or streaming. So when we're visiting with our states, we want to talk about how they can make use of assets that we have, and also co-branding. We haven't yet started to, but we are looking forward to co-branding some of these assets with state efforts with our REACH campaign. Next slide. So we're going to show you, some of you may have seen this last week. This is just a short little 40-second video that is a new asset that we are creating that will be out soon. So why don't we go ahead and roll the video. I love this whole campaign. The message is very powerful. It's a bi-directional message. We are encouraging all of us to learn about risk factors, protective factors, dispel the myths around suicide, learn how to talk to people. We're identifying resources, and we're really working to reach people who are hurting, who are struggling, so that they reach early for help. And we're breaking down barriers, the cultural barrier being a huge one. So this campaign, we want your help. We want your governor's help pushing this out on state level. So we'll talk about that when we come to visit you as well. Next slide. So this is what the REACH campaign is looking like so far. We have ads like the one you just saw. There's another ad that some of you saw last week that's very powerful that we use to take over YouTube. So far, we have created 2 billion with a B impressions. So we are saturating as in as many different ways and on as many different platforms as we can possibly find. We've had more than 6 million visits to the REACH website, which is massive, and more than 10,000 people have taken the Prevents Pledge to REACH, which we want all of you to take. You can take it as an individual, you can take it as an organization, you can take it as both. And also what we are seeing, which tells us that people are interested. They are interested. When people click on the videos like that one or others, we have a 70% completion rate. They are watching the video to the end, which is far above industry standards. So clearly people are interested in this effort. Next slide. Okay, back to our goals. So those are some of the things, talk about the proclamation, what's in it, what we want to do together, promote the REACH campaign. What does that look like? How can you be involved? How can we share assets that you can use in your local efforts? Can you imagine a full page ad in local papers that say REACH? We have all that stuff, so we want to work with you to do that. We also have a state, an ambassador program through Prevents. We have national ambassadors. We have 21 of those. We are 22 now. We just got a new one. Plus, one of our ambassadors is a canine ambassador. We also have state ambassadors. So we want to make sure that we have state ambassadors in every state, and we provide talking points and toolkits. We make sure that they're up to speed with all the work that we're doing. We share assets. So we want to make sure that your state has good state ambassadors connected, and we can share with you how to become a state ambassador. You can nominate yourself. You can nominate someone else to weareprevents@va.gov. And then we do the vetting. We check to make sure that everyone, is in sort of good status in their profession. It's not a high bar, but meaning you don't have to have accomplished amazing feats to become a state ambassador. You have to be passionate and be willing to work with us and to push out this information. So this state ambassador effort is a great way for us to work with our state partners. Next slide. The other thing that we do when we come to visit with you is we identify partner organizations. Who have we met with that might end up working with us on a national level or at a state level? We engage our faith-based communities. Again, we have toolkits, we have assets, and we're gathering information from programs to contribute to the database. And what we eventually will be a very easy collection of best practices that state leaders, community leaders can refer to, so they don't have to start from scratch if they want to create an effort that's focused on suicide prevention within the veteran and military community in your state or your community. Academic institutions like Syracuse, you know, every time we go out visiting to states, we typically pick up a couple of academic institutions who we find out what they're doing, they learn about what we're doing, and then we form partners. And obviously, we really want everyone to be involved, and every individual can be involved with Prevents by taking the pledge, and then by following what we're doing and promoting and supporting efforts in your community and letting us know what's happening that is making a difference. Next slide. So what have we learned as we've gone into our states? So we've learned that the state visits are a great way to exchange information. Nothing beats it. You know, we can't do this from Washington, where many of us are, although my team is spread out all over the country. You know, I told you I grew up in rural California. My community didn't even have a high school. My brothers had to get on a bus to go to their high school. We know that the work happens at the community level. We know that we can only grow and collaborate if we are working together. So we can do webinars, which are one way, but those state visits, being able to sit around either in person around a table or virtually, we learn so much and we share so much and we form partnerships. We know that there are great programs in states all over the country. And so by gathering information, and then we are working closely with the gentlemen who are going to follow me in this presentation, constantly talking about, okay, we just learned about this. What's happening over here? How do we plug these together? How do we develop a partnership around this opportunity or this effort or this idea? We also are learning about what challenges are facing various states and communities. Many of them are shared. So that's very helpful for us to learn, because then remember I talked about the funding, what we can bring and what that could look like going forward. We learn what challenges there are that we can help you overcome. And we learn what you're doing to overcome those challenges. And if there are unique things that are only happening in a certain state, then we may be able to find a partner and say, you know what, this is happening in Montana. Maybe it's a broadband issue. And maybe because we partner with some major telecommunications companies through the VA, maybe there's a way to put those together. We can see where improvements need to happen. And as I said, we can find out where support is needed. Next slide. So we are planning visits between now and March 2022 because we want to visit all of our states before the task force itself sunsets. The work will continue. REACH is going to go on for many, many, many years, as will this overall effort. But between now and 2022, we're planning our state visits. So if you are interested in finding out either when we're planning to come to you, or you'd like to say, hey, we don't want to wait until a year from now, we'd like to get you guys in sooner, send us a note and we'll work with you and your team to figure out what makes sense and then start the planning process. Next slide. So I just want to end you with thank you for all that you're doing. We look forward to working with you, to meeting with you, to learning, finding out how we can elevate and support. Please take the Prevents Pledge to REACH. It's very easy to do. We are within reach.net. You can find the pledge, take it, take a picture of it, post it, get everybody you know to do the same. Together we will prevent suicide. So now I'm going to turn this back over to Ilario so that he can introduce the next speaker, and I look forward to coming back at the end of the program to answer some questions that you all have posted for us.
Thank you so much, Dr. Van Dalen. And to our audience, please continue to use the question and answer function. We'll be attempting to answer these questions in real time, and we'll also be circulating a answer response after the webinar. So thank you so much for that. It's a pleasure to introduce Dr. Richard McKeon. Not only does he helm the efforts at SAMHSA, but as a former state director, SAMHSA has been very instrumental in my own experiences in supporting state suicide prevention efforts, and really grateful that you're on with us today, sir. Dr. McKeon serves as the Suicide Prevention Chief of SAMH at the SAMHSA Center for Mental Health Services. He oversees all suicide prevention branch activities. That includes the Garrett Lee Smith State Tribal Youth Prevention and Campus Suicide Prevention Grant Programs, the National Suicide Prevention Lifeline, Suicide Prevention Resource Center, and the Native Aspirations Program. Dr. McKeon spent most of his career working in community mental health, including 11 years as a director of psychiatric emergency service and 4 years as associate administrator and clinical director of a hospital-based community mental health center in Newton, New Jersey. He was appointed to the Secretary's Blue Ribbon Work Group on Suicide Prevention by the Secretary of the VA in 2008, and the Department of Defense Task Force on Suicide Prevention in the Military by the Secretary of Defense in 2009. He served as the National Action Alliance for Suicide Prevention Task Force that revised the national strategy for suicide prevention and participated in the development of the World Health Organization's World Suicide Prevention Report. Dr. McKeon is also co-chair of the Federal Working Group on Suicide Prevention. He received his doctorate in philosophy and clinical psychology from the University of Arizona and his Master of Public Health in Health Administration from Columbia University. With that, Dr. McKeon, thank you so much.
Thank you. It's a pleasure to be talking with you today. What you see before you is just standard disclaimer that much of what I say will be my point of view, does not necessarily represent the view of SAMHSA, the U.S. Department of Health and Human Services. So in short, if I say anything you don't like, blame me, don't blame SAMHSA. So let me start by, for those of you who may not be familiar with SAMHSA and its programs, let me just review with you our suicide prevention activities. And additionally, SAMHSA has many other programs focusing on mental health and substance abuse prevention and treatment. So one of our oldest suicide prevention programs is our Garrett Lee Smith State and Tribal Youth Suicide Prevention and Intervention Program. These grants at one time or another since its inception in 2005 have gone to every state in the union as well as many different tribes. In addition, it's important to note that our published evaluations of the effectiveness of our youth suicide prevention grants have shown that counties that were implementing grant-funded suicide prevention activities had lower rates of youth suicide and youth suicide attempts than matched counties who were not. And that this impact was greater the longer the years of continued funding of such activities. What this shows is, first off, that we can prevent suicide in communities across the country. It is challenging, but it obviously needs to be resourced. And the fact that counties that were doing 2 years of activity had stronger impact than those who did 1, that those who did 3 years had a stronger impact than 2, 4 than 3, etc., is very powerful evidence of the importance of this. I'd also like to point out that this grant program, it covers age 10 to 24, but the 18 to 24-year-old age range, where we've seen nationally significant increases in suicidal ideation and attempts, as well as deaths by suicide, also incorporates many service members and our younger veterans. So I think that that's also important to be aware of. SAMHSA has a campus suicide prevention grant program that provides grants to all kinds of college campuses, private universities, community colleges, large public universities and state university systems focused on suicide prevention within college campuses. And of course, many college campuses have programs for veterans who may be returning to college following their service. So also potentially an important piece of veteran suicide prevention. SAMHSA has a program called Zero Suicide in Healthcare Systems. Really, it was modeled on some of the work in the Henry Ford healthcare system, but also the great work that the Veterans Health Administration really began to ramp up in 2007 about making suicide prevention and everything we know about the evidence base for clinical suicidology and to making it central in healthcare within the VA. In many ways, the Zero Suicide effort is an effort to take many of those same practices and protocols and embed them in healthcare systems all across the country. SAMHSA has a National Suicide Prevention Resource Center at www.sprc.org. It provides support for state suicide prevention coordinators. It provides support for the National Action Alliance for Suicide Prevention. It is probably the website with more resources for suicide prevention than any other website in existence. So we would urge you all to go through that. It's existed since 2002. SAMHSA has what are called the National Strategy for Suicide Prevention grants. This is aimed at a comprehensive approach to suicide prevention among adults. We have a large program called Native Connections, or Tribal Behavioral Health Grants. There are almost 200 grants to tribes and tribal organizations in American Indian and Alaska Native communities across the country. These grants focus on youth, preventing youth suicide in those communities and youth substance abuse. Also provide support to urban Indian organizations. And then we have the National Suicide Prevention Lifeline. The National Suicide Prevention Lifeline, which has the option, if you call the number 1-800-273-TALK, to press 1 to be connected to the Veterans Crisis Line. In 2019, it answered over 2.1 million calls. There are currently 175 crisis centers in all 50 states answering those calls. And we are currently embarked in a major transition and transformation. The FCC in July of this year gave every cell phone provider, every landline provider, every voice over internet provider in the country 2 years to make the number 988 operational as the new National Suicide Prevention number. Now, the 273-TALK number, those calls will still get answered, but we anticipate that 988 will reach many more Americans. So this is something for every state, every community to be aware of and to be planning with stakeholders within your communities, within your state, sharing your thoughts with SAMHSA and the VA, so that when we get to full implementation of 988 across the country, that it's informed by everyone's best thinking. We also have what we call crisis center follow-up grants. This is to help Lifeline centers systematically follow up with people at risk, either people leaving who had made a call who were suicidal or might be leaving an emergency room or a hospital. And we are particularly glad to be working with the Veterans Administration on the Mayor's and Governor's Challenge work. These, I'll talk a little bit more about that. Those are done through SAMHSA's service member veterans and their family TA center. And Barbara kindly mentioned those efforts previously. And then I also want to mention SAMHSA earlier this summer issued 50 COVID emergency suicide prevention grants because of our concern that the already increasing level of suicide in the United States that was taking place even before COVID could be even intensified now. The CDC issued a recent report indicating significant increases in people considering suicide, which is obviously of a great concern. But we know that a person who thinks about suicide does not necessarily, in fact, it's relatively uncommon, that they would act on killing themselves right away. So our goal for all of us is to make sure that these increases in people seriously considering suicide in the current environment does not translate into increases in suicide deaths. That is certainly our major goal, and part of what these COVID emergency suicide prevention grants, as well as efforts that SAMHSA has taken to strengthen the National Suicide Prevention Lifeline and the Disaster Distress Helpline, are aimed at doing. So can we move to the next slide? So I mentioned, of course, the Governor's and Mayor's Challenge, and we have been very grateful to be working on this. We've been grateful for the conversations with Barbara and the Prevent teams about the work that has gone on. And this is really I said, it's a cross-agency collaboration. And anybody who works in government or with government knows that it's very easy for efforts to be siloed. You know, silos are kind of like gravity. They're always kind of pulling you down if you don't work actively to overcome them. And that's what the Governor's and Mayor's Challenges have been doing. You know, it's an effort between SAMHSA and the VA, and where other partners have been engaged, including the Department of Defense and the CDC and others, to work together, because we know that suicide prevention can't live only in one particular program or one particular federal agency or one particular private organization. We all must be involved. We all must need to collaborate and coordinate in order to have the maximum possible impact, in order to do what we all so want to do, which is to reduce suicide in the United States. So you can go to the next slide. So this gives you a sense of some of the early work that was done, some of the cities that were engaged in the Mayor's Challenge work. And then we moved on to last year to have 7 states that participated in the Governor's Challenges. And then we also, this past year, or this current fiscal year that's just, well, I guess that just ended, expanded to many additional states participating in the Governor's Challenge work. And I've had the privilege of being able to do some visits to and be obviously involved virtually to learn more about some of the great efforts that have taken place as part of this in cities, states, and communities across the country. Next slide. So the Governor's Challenges have had 3 focused priority areas. One is identifying service member veterans and their family, because we engage them across all of our systems. It's not only within the VA, but many times we don't ask the question about, has the person served in the military? So identifying that someone is a service member, a veteran, or a family member, and also screening for suicide risk. These are both questions that need to be asked more routinely. Are you thinking about suicide? As well as understanding if somebody is a service member or has served. The second focused area is to promote connectedness and to improve care transitions. And wasn't the video that Barbara showed a wonderful example around promoting connectedness? And then third, increasing lethal means safety and safety planning, right? We know now from solid evidence that safety planning is effective in reducing suicidal behavior. So those are not the only areas of work within the Governor's Challenges, but they are particularly important priority areas. Next slide. I just want to give you an example of some great work that came out of the Mayor's Challenge work. The Houston's Mayor Challenge focused on improvement of transitions in care and services. And one thing that led to was a memorandum of understanding, a care coordination agreement, which allowed warm handoffs between the Harris Center, which is the major community mental health provider for the city of Houston, and the Houston VA. So that if you are in Houston and you are a veteran, no matter which hospital you go to, which agency you connect, if you are in crisis, that the Houston VA and the Harris Center are coordinating your care to make sure you don't get lost between the cracks, which happens too often in the United States, that people fall through the cracks of our fragmented crisis and emergency system. Improving that system has been a major priority for SAMHSA. So this was a major accomplishment that came directly out of the Mayor's Challenge. And as part of the Texas Governor's Challenge, they're working on establishing just these kinds of memorandums of understanding between every VA in Texas with every mental health authority in Texas. Next slide. So another piece of work that SAMHSA has been supporting as part of the Mayor's and Governor's Challenge is called Crisis Intercept Mapping. Basically what this is trying to take a systematic look within a community about where are veterans encountering the community and emergency mental health systems. So for example, when I was in community mental health in New Jersey, I worked at a hospital in one county. Well, there was, in New Jersey, there's only 2 VA hospitals. And of those 2 VA hospitals, only one had a VA emergency room. That meant if a veteran was brought by ambulance to a hospital emergency room, only in that one county would they end up getting in a VA emergency room and then being able to be linked potentially through the Veterans Crisis Line to the State Suicide Prevention Coordinator. So exactly that kind of high level of care that VA is doing internally, this is an effort to bring to every community for veterans, no matter where they may encounter a community system. And some wonderful things have flowed out of this. Let me give you an example. In Montana, they did crisis mapping work in 2 of their cities. And they indicated that they had a major gap in terms of the absence of mobile crisis outreach services. They worked on that together with veterans organizations, with mental health organizations, and it led to the state of Montana passing an initiative to greatly expand mobile crisis services within the state for veterans, but not only for veterans, for all residents of the state of Montana. When I went to Los Angeles for their crisis mapping, I learned how they were working, how a mobile team in a VA center in Long Beach was collaborating with the mobile crisis teams in the city of Los Angeles. So some great work has come out of this. Next slide. And again, so as I said, closing the gaps in crisis services is the aim. We've also worked closely with the state of Virginia, who have worked to expand their efforts starting in the city of Richmond and to bring that statewide, just as in Texas, they've done work to do the same. Next slide. And one of the areas that I want to close with, I mentioned earlier, we are moving toward 988. Now, the number 988 calls to mind the number 911. It's important to mention that 911 has been the linchpin over a half a century of improving the system for emergency medical systems in the United States. So it's not only the number, it's the fact that it played a central role in making things better. We hope that 988 over time can play a similar role to improve mental health emergencies and crisis services across the country for the nation's veterans, no matter where they may intersect with those services, as well as for the nation as a whole. Next slide. And that's it for me.
Thank you, Dr. McKee. And it's going to be my pleasure to now introduce Dr. Matt Miller, who is the VA's Director of Suicide Prevention for all of the VA departments. I'm going to give you a little bit of an abbreviated background. First, a little bit of a housekeeping issue. We're beginning to run a bit over time. What was intended originally as a 60-minute webinar, we've scaled to 90 minutes so that we could afford a question and answer session at the back end of the webinar. I'm going to ask and invite all of you to please remain. There's a question and answer feature that we'd love to enjoy, and we'd love to be able to look at using a portion of the time still allotted for question and answer. But first, we're going to have an important presentation from Dr. Matt Miller. He's got a 70-person team dedicated to the implementation and reinforcement of evidence-based community and clinical interventions addressing suicide prevention, intervention, and postvention for 19 million veterans nationwide and 140 plus VA healthcare systems. Dr. Miller previously served as the director of the Veteran and Military Crisis Line and was privileged to oversee the extensive growth, including the creation of a third call center, which increased staffing to 900 full-time employees. There's more to Dr. Miller's background, but I want to jump a little bit to his service, where he served as an officer and clinical psychologist with the United States Air Force. He completed his professional residency in clinical psychology at Wright-Patterson Air Force Base Medical Center. He served as the chief of mental health at Joint Services Pilot Training Wing, overseeing outpatient mental health operations for all active duty members and dependents within the installation community, and is head of the installation suicide prevention, alcohol and drug demand reduction, critical incidents response, and family advocacy programs. Dr. Miller has been awarded for his work and look forward to hearing from him. His personal story in treating service members and peers and fellow officers is very powerful and impactful. With that, Dr. Miller, to you, sir. Thank you for joining us.
Great, thanks for having me. My pleasure, my honor to be here with you today. And thank you to you and the team for organizing this. Barbara, Richard, and I all know that organizing something such as this requires a lot of people backstage and a lot of people working really hard. So thanks to you and thanks to the Prevents office as well for all the work done, including helping me figure out audio at the last second. So thank you very much for that. You know, I was thinking today centers around two words, partnership and public health, within the context of suicide prevention. The word partnership took me back as I was thinking about, well, what does it really mean? How important it is. My mind, I wouldn't be a clinical psychologist, I guess, if I didn't go back into childhood, but my mind went back to elementary school. Remember the days when the teacher would say the infamous phrase or words, find a partner? Well, a lot hinged on being able to find a partner back then, and you had to know how to negotiate in some cases there to find the right partner. For example, I knew that if the partnership task was math or science oriented, I would probably have to bring a fair amount of Nutter Butters or Oreos to the table for that task to get the right partner. However, if it was gym or PE or something along those lines, that was my chance then to collect the Oreos or the cream pie. So partnership hinges beyond Red Rover or something along those lines. Partnership hinges, I think, upon some foundational words that create a good, strong partnership. It's founded upon a shared understanding. It's founded upon a shared vision. It's founded upon shared priorities. And it's founded upon shared and collaborative actions. I think of those words, and I'm so grateful for all of you, and I'm grateful for Barbara and Richard and the teams that they represent, because we in the VA and suicide prevention program enjoy a strong partnership with Prevents. We enjoy a strong partnership with SAMHSA and the teams. I think you'll see that reflected within what we talk about as you hear the overlap, and you've already heard it with Barbara and Richard in many cases. Now, a shared state of understanding, a shared state of vision, a shared state of priorities, a shared and collaborative state of actions requires a situational awareness that is grounded in facts, is grounded in truth, and also is common. You've heard some of these situational awareness facts. I call them theater of operations, and there's really three that I think we need to be on the same page with regard to, and I know we are with Prevents and with SAMHSA. Theater of operations fact number one right now when it comes to suicide. Suicide affects all Americans, not only service members and veterans. We see this in the fact that suicide is the 10th leading cause of death across the nation, second leading cause of death in my daughter's demographic of 10 to 24 years old. 44% increase in raw count just over the last 15 years. Theater of operations fact number two. Suicide has been on the rise in America for 20 consecutive years. 2% annual increase at least nationally overall, 1 to 2% increase in VHA veterans, about an 11% increase in non-VHA veterans year to year. So it's one of the top 10 that is somewhat unique in that it's not showing any signs of going back, flattening. It continues to rise, and you see that with the 2018 data from the CDC. Theater of operations fact number three, as a group, veterans are at elevated risk for suicide. Some populations have higher risk than others. Overall, about a 1.5 times greater risk. If you then subdivide that into male and female, male about 1.3 times greater risk, female about 2.2 times greater risk. 18 to 34-year-old veterans have the highest rate of suicide, and veterans 55 years of age or older have the highest count of suicide. So we have a shared understanding of the issue in terms of situational awareness and theater of operations. So now let's spend some time talking about vision, talking about plans, and talking about actions. Next slide. Perfect. Thanks for your help with that, by the way. From three theater of operation facts to three core beliefs. Three core beliefs that I think you've heard. They unify all of us, I believe, and it's interesting as you hear these that you say, oh yeah, I heard Dr. Van Dalen say that. Oh yeah, I heard Dr. McKeon say that. Number one, suicide is preventable. Number two, suicide prevention will require a public health approach. Number three, suicide prevention will require all of us. These three core beliefs are then translated into short-term and long-term strategic plans within the VA and together with Prevents, SAMHSA, and with you. Because the three core beliefs, next slide, because the three core beliefs unify us across understanding, vision, plans, and actions, I'm going to spend the rest of the time checking the time. I'm going to spend the rest of our time walking carefully through each. First, let's talk a little bit about suicide is preventable. Next slide. Perfect. It makes sense that this is the first of the core tenets. It makes sense that why we get up in the morning or in the evening and why we're here today is because we believe in our heart of hearts that suicide is preventable. If we didn't believe that, why would we be sitting here? Why would we be doing this? But as simple and straightforward as that seems, this is the core belief that I struggle with the most. The reason is because if suicide is preventable, what does that mean if it happens and when it happens? That means in a lot of cases then, well, it must have been avoidable. And that turns into finger pointing. That turns into blame. That turns into accusations. That turns into someone must be accountable or responsible for this. That's very difficult for me because I experienced that firsthand, and the judge and jury lined up against me was myself. You heard about my background with the military and the Air Force. When I received my residency, my assignment post-residency, I went into my commanding officer's office. I stood at attention on assignment day, and she told me what my assignment was. And it was nothing that I had selected. I was given a list of 24 choices, and this was not on there. So she must have seen the look on my face. I don't have a good poker face. And she said, "Captain Miller, at ease, have a seat." She said to me, "Matt, you need to understand that we would not assign this to anybody else." It started to feel like your parents talking to you and saying, "This is for your own good, you'll thank me later." But she said, we wouldn't have assigned this to anyone else. You're going to be the only uniformed mental health provider here. This is a what they call Lone Ranger slot. This is joint services. This is international. And the opening came, and we selected you. We trust you. That weighed heavily on me as I took that very seriously. When I was assigned there and then engaged, I was in charge of everything from outpatient to substance use to suicide prevention. I became really close friends with 2 Marines who were Cobra drivers and instructor pilots there, flight commanders as well. Towards the end of our eventful time there in 3 years, John was tapped for deployment, redeployment in his case, and we had a party, and I think it was a couple months later I got a knock on the door from my sergeant, and she said, "Sir, I have bad news," and she went on to tell me Nuts is dead. I asked how. I thought it was a training accident, and she said suicide. Probably just a couple minutes later, I got a call from my other buddy, the Marine Cobra driver as well, and he asked me questions that still stick with me. Did you know? What did we miss? And my lack of answers to those questions, I went through a dark period, and I am sensitive to that when we talk about suicide being preventable. I want to steer away from the aspects of it, of blame, of of culpability, of responsibility, yet taking extreme ownership for suicide prevention. And focusing on these aspects, I think, of suicide being preventable does so. Number one, suicide is preventable at the individual level. We see this on this slide with some data we have from the VA. We see a declining rate of suicide among veterans in recent VHA care with a diagnosis of depression. We see suicide rates among veterans in recent VHA care rising slower and lower than veterans not within VHA care. There is not an increase in suicide rate for female veterans in VHA care. You take that together and there are things that work. There are things that you can do. Next slide takes it a step further and takes a look at population level. Richard talked about some wonderful programs they have at a population level that work. Another one, we know according to our clinic practice guidelines that lethal means safety works. We know that it's effective, and it's one of the established approaches that is effective at the population level for suicide prevention. But don't take my word for it, as they say on TV. Let's talk about the mechanisms here for just a couple minutes, a little more specifically. Next slide. All right. So here's some of the TikTok behind the statement that I just made. Building in, and what this graphic will show you, is building in time and space between the impulse to act and the means to harm yourself can save lives. While some suicidal crises do last a long time, most last minutes to hours. For example, if you check this out, in one study of suicide attempt survivors, 48% said it took less than 20 minutes, 24% said it took less than 5 minutes for them to go from decision to implementation. 71%, the majority, said they took less than an hour. This reality underscores the importance of reducing access to means for those who are at elevated risk for suicide until the risk period passes. Some key points to remember within this. I think I have 3 or 4. Number one, access to lethal means increases suicide for everyone living in the home. The acute phase of suicidal crisis is often brief. That's why it's so important that at Veterans Crisis Line we answer the phone within 8 seconds. Building in time and space, even 30 to 60 minutes between impulse to act and means to self-harm saves lives. We also know that people rarely substitute one means for another, so it's important to restrict whichever means they have in mind to use. People often say, well, why bother? If I restrict or I limit access to this means, another will just be found. That actually doesn't hold to the research. If you go to the next slide, I want to show you how meaningful this is to the veteran population. 70% of veterans who died by suicide did so secondary to self-inflicted firearm injury. 48% of non-veteran adults suicides were from firearm injury. This table shows you the disproportionate representation in the veteran population with firearms and death by firearms. So a big difference can be created and impacted in this area at the population and individual level. Again, this is all under core tenet number 1, which is suicide is preventable in the constructive way of viewing that. Core tenet number 2, and next slide. Thank you. Suicide prevention will require a public health approach. All right, so even if you have a degree in public health, you can kind of scratch your head and say, what does that really mean? Well, we know, clinical care matters when it comes to suicide and suicide prevention. 60% of veterans who died by suicide in 2017 had a mental health diagnosis. We know that the rate of increase within VHA care was significantly lower than the rate of increase in non-VHA care. But we also know the majority of veterans were seen within primary care, not mental health, within the last 6 months of their life. We also know, and this was mentioned previously by Barbara, 11 out of 17 for that average per day are not active in VHA care. So we need community-based prevention and intervention efforts focused on vocational development and instability, financial literacy and instability, social support, and access to whole health resources and support. Next slide gives a bit of a representation of this. And my time is about up. Next slide, this gives a representation of this if you were to put this in a additive way. Our model of public health applied to suicide prevention incorporates community-based plus clinically based in a prioritized manner. What does that look like? Next slide. We have 3 community-based prevention strategies. Richard has talked a fair amount and adequately, much better than me, about the governor's challenge. We also have what's called a VISN, that's our regional network of healthcare systems. We have a VISN-based model of community coalition building. We have a veteran-to-veteran based model of suicide prevention coalition building. On the clinical side, we're really focused in the next 2 years on the deployment of increased access to and provision of an evidence-based approach to suicide prevention, and that is cognitive behavioral therapy for suicide prevention. The next slide gives you an overview of what we're eyeing in terms of outcomes within the community domain and within the clinical domain. Let me wrap up with core tenet 3, which is suicide prevention will require all of us. So this is where we come back to partnership. It's through partnerships, and only through partnerships, that we're able to expand our reach upstream to service members before their military to civilian transition, to veterans, whether they receive care from the VA or elsewhere, and to and within the communities where the veterans, our veterans, live and work. The last slide gives you an overview of how the model leverages the complementary and intersecting dynamic between national, state, and local dimensions. And that's actually, I think, one slide before this. And that'll give you a bit of the Venn diagram where you see the national, you see the state, you see the local, and then you see the different programs. There it is. Thanks so much for that. And the importance then of having that overlap from a suicide prevention perspective. So, in conclusion, partnership. So honored and privileged to be partnered with Richard, with Barbara, with their teams. I do believe that we have shared understanding, shared vision, shared plans, and shared actions. I believe that those are grounded in awareness of some important theater of operation facts. I think that those then help to cement the 3 core beliefs of suicide is preventable. It's why we do what we do. And there's constructive ways to implement that. Suicide prevention will require a public health approach, clinical, community, downstream, upstream, universal, selected, indicated, all together. And then finally, we all have a role to play. That's the theme of REACH and the REACH campaign. That's the theme of Be There and the Be There campaign as well. So I'll conclude with that, and thank you for your time. And then Nick, I think sounds like we're going to have a little bit of a Q&A led by you. So I hope I didn't take too much time from you.
Dr. Miller, that was tremendous. I just want to say thank you so much to our audience. We're going to run to the top of the hour here. We've got about 8 minutes still reserved for a question and answer session. Dr. Armstrong is the Senior Director at IVMF for Research and Analytics, and he's also adjunct faculty at Maxwell School of Citizenship and Public Affairs at Syracuse University. He's got a distinguished biography. I would point out that he's a West Point graduate, a Ranger, and also has earned 2.
Laria.
Did I have the pleasure of giving that biography on mute?
You did, but we can jump right in. Thanks, Ilaria.
Thank you so much.
Appreciate that. Let me echo my IVMF colleagues in thanking Dr. Van Dalen, Dr. McKeon, and Dr. Miller for their leadership and partnership on this critical challenge of preventing suicide, and thank each of you for your rich and thoughtful presentations here today. It's a privilege to spend the last few minutes here of our time together for a few questions from our participants, which come from a range of different state and local agencies, veteran serving organizations across the country. I actually want to start with one question, just like thinking about the theme that we've heard throughout, and that's about partnership and collaboration. You know, particularly amongst federal partners, and maybe even like digging into the state and local agencies. Maybe Dr. Van Dalen, you could talk a bit about some of the challenges you've seen and how you're addressing those.
Thank you, Nick. And I want to thank again my colleagues, Richard and Matt, for joining this conversation. And I want to encourage all of you who are with us today to come back for the third installment, because one of the things that I'm going to propose is that we provide a half-hour chunk just to answer questions, because I saw some great questions. There's so much going on. I think you could tell that all three of these presentations are like bursting from the seams with so much information to share. And we really want to be able to respond to specific questions. So I'm going to talk with the IVMF team and my team, and I think we'll give a good chunk of time next week, or excuse me, in the following week. I think that's our final installment of this 3-part series. So that's sort of like a Hollywood tease, right? So if you want to see the answers to these questions, you're going to have to come back and be with us again. But we've captured all of your questions from today in the chat, and there were some great ones that we can answer. So, but I think this is a nice one to really sort of end with, and I'll ask Matt and Richard to share some of their thoughts as well. It is a challenge to work together. You know, any individual, as bright as he or she may be, any organization may have a great vision and a great plan, but the secret sauce, the challenge, and the opportunity is really the working together. And so even though prevents, the mandate of this executive order was to create an all-of-government, all-of-nation approach, there aren't shortcuts to work together. So Matt and I talk regularly, or I text him with a new idea or something that has come up. I just reached out to Richard a week ago and said, Richard, can you hop on the phone so that we can talk through this opportunity that has come up? It is challenging. The challenges are primarily not because there isn't the interest and the passion and the commitment, but the challenge is because everyone is so busy. There's so much on our plates. We are working through so many different elements and pieces. And so what do? We build in those opportunities to make sure we have working groups, we have an implementation steering committee, we have ongoing, we do this because I have, over the last 15 years of doing this work, I've not found a shortcut. Same thing with our non-governmental partners and our state partners. That's why we have a large team, although our core team is actually teeny, but we have other folks supporting us in different ways through our MOUs that we create with partners. But then you can't just create it, you have to go and actually work it. I guess my comment on this, and then I'd like to ask Matt and Richard to give their 30-second response, and then we'll have you all come back and we'll answer some more of these nitty-gritty, is there really is no shortcut to this. You have to put in the time and energy, you have to create those situations, and you have to be mindful about engaging It's challenging, it is doable, but it takes all of us to be committed to that type of level of ongoing partnership. So, Richard, what do you want to add to that? Do we still have Richard? He might be on mute. There he is.
I'm here. So yeah, I certainly agree with you entirely, Barbara. And I think that it is challenging, but so necessary. And that the issue is principally, time demands on very busy, committed people. But the payoff for collaboration is so important, because multiple disconnected good things does not necessarily add up to effective national suicide prevention. And some things need to be synchronized. Colleagues in Europe who did the European Alliance Against Depression emphasized that some of the success they had in reducing some national suicide rates in a couple of countries came about because their efforts were synchronized and coordinated across multiple areas and with multiple organizations, and that there's synergy from doing that. And so these are so I think that I agree 100% with Barbara's comments about this. I do think that the issue of can prevents and reach be compatible with the governor's challenge? I would say absolutely they are compatible with the governor's challenges, because it's all about a public health approach, as Dr. Miller has emphasized. It's about a comprehensive approach. It's about a coordinated approach that's not disconnected and that's not fragmented, and where efforts can complement each other and not compete with each other.
Beautifully said. And Matt, what would you say, what are your last thoughts on that? Because, and again, this is a tease. We'll have everyone come back and we'll answer some more specifics, but what do you think about that, Matt?
I read a piece not too long ago that said the one thing that America is missing when it comes to suicide prevention is collective engagement. And it was comparing to some other countries, two of which have seen rates go down, one of which has held low rates. It said we were lacking collective engagement. I took that a little personally, and I think we can start with ourselves and our teams and demonstrate collective engagement over the long haul.
I love that. Yes, beautifully stated. I think that's all we've got for today, Nick and Ilario, but I again want to thank everyone for joining. This is so important. There is no shortcut. We are passionate and committed to sharing this information and to working with you. And I'm excited that I think in the final one, now that we sort of know how to do these, and we've got a lot more opportunity to share, we'll come back together. We'll share, again, a deeper dive. And then we'll take a lot of time to answer your specific questions, and you will be one of our working groups. So thank you very much, again, to IVMF for being such a great partner to put this on.
Thank you.
It's been a tremendous pleasure, and to our audience, it's terrific to see that we still held as many participants through a 90-minute session of really wonderful deep dives. To all of our presenters, to Dr. McKeon, to Dr. Miller, to Maureen Casey, to Dr. Nick Armstrong, whose biography I wasn't able to share, but is esteemed. Thank you all for your participation, and for the audience, please, we hope that you come back in 2 weeks. You can register at the same place that you registered for 101 and 201. And a subsequent thank you note will have links to the video presentation as well as to the slides. So again, thank you so much all for joining. We appreciate the efforts.